Today's topic is oligohydroamnios versus polyhydroamnios. Oligohydroamnios. AFI is the amniotic fluid index and SVP is single largest vertical pocket. Now the normal value of AFI is 5 cm to 24 cm, whereas SVP is 2 cm to 8 cm. So when the AFI will be less than 5 cm and SVP will be less than 2 cm, we will consider it as a oligohydroamnios. Most common cause of the mild is idiopathic, whereas the severe it can be because of fetal renal anomaly. Renal anomaly will include renal agenesis or posterior urethral valve. The question asked is, what is the structure of posterior urethral valve? So it will be look like a keyhole. Other causes can be decreased transudation. Decreased transudation can be because of small placenta. It is seen in pregnancy-induced hypertension, IUGR, or uteroplacental insufficiency. Decreased urine output. Decreased urine output can be because of renal disorder and drugs like AC inhibitor and indomethacin. Hence, indomethacin is a drug which can cause oligohydramnios. So, we can use it as a treatment of polyhydramnios to reduce the amniotic fluid. Decrease amniotic fluid volume. It can be in the postpartum pregnancy, premature rupture of membrane, or leakage. Then chromosomal anomaly like triploidy. So it is all about oligohydramnios, AFI less than 5 cm, SVP less than 2 cm. Mild is idiopathic and severe is renal anomalies. Other causes will be decreased transudation, decreased urine output, decreased amniotic fluid, and triploidy. Next comes polyhydramnios. Polyhydramnios AFI will be more than 25 cm and the upper limit of AFI was 24 cm. SVP will be more than 8 cm. Mild cases is idiopathic, whereas in severe fetal GIT anomalies can be seen like esophageal atresia, duodenal atresia, cleft lip, and palate. In duodenal atresia, we will see double bubble sign. Other causes can be increased transduation. In oligo, it was decreased, whereas in poly, it is increased transduation seen in the placentomegaly. Conditions can be diabetes, twin pregnancy, or Rh negative pregnancy. Increase urine output, as in the twin pregnancy, diabetes, Bartter syndrome. Bartter syndrome is a syndrome in which kidney will lose more minerals and salt. Fetal anemia include thalassemia, Rh negative pregnancy, and parvovirus. So, increased urine output can be because of twin pregnancy, diabetes, Bartter syndrome, and fetal anemia, that is thalassemia, Rh negative pregnancy, and parvovirus infection. Now comes increased transduction from the fetal skin, usually because of neural chip defect or abdominal wall defect. A chromosomal anomaly is trisomy. Here it was triploidy. Okay, in oligo it was triploidy, whereas in the poly it will be trisomy. Now, condition in which both oligo and poly can be seen is twin to twin transfusion syndrome and torch infection. So it is all about oligo and poly. Now, how will you approach the case of oligo and poly? So step one is fundal height. When we will manually see fundal height, it will not be equal to the gestational age. So we will do level 1 scan on USG. In the step 2, if there is a mild oligo or poly, no further evaluation needed because it was idiopathic and it will get better soon. If the condition is of the moderate or severe, we will do target anomaly scan, that is level 2 scan. And step 3 is anomaly detected. If any gross congenital anomaly is detected, we will go for karyotyping. Step 4, we will rule out polyhydramnios by ruling out diabetes and fetal anemia. In fetal anemia, middle cerebral artery peak systolic volume will be more than 1.5 mmol. And in oligohydramnios, we will rule out PPROM and uteroplacental insufficiency. Umbilical artery Doppler, we will find S by D ratio will be more than 3. Now, peak systolic volume of middle cerebral artery. If it will be the more than 1.5, then we will consider it as a fetal anemia. If it is less than 0.8, we will consider it as a polycythemia. Now, indomethacin, as I mentioned above, indomethacin can be used to treat the polyhydroamnios. Side effect will be premature closure of ductus arteriosus, and contraindication is after 32 week of pregnancy you can't use cardiotocography in oligohydramnios. Most common finding is variable deceleration. Persisting variable deceleration is the only indication for amnio infusion. Remember this. If you have to do amnio infusion, then the only indication is persistent variable deceleration seen on the cardiotocography. Syndrome related to oligohydramnios, that is a Porter syndrome due to the kidney defect. This baby is having the Porter syndrome. You can see that the face is turned to the one side, his whole body is turned to the one side, limbs are folded. You can see the flat face. Now, Porter syndrome features are severe oligohydramnios, lung hypoplasia, flat facial features. Second syndrome is amniotic band syndrome. Amniotic band syndrome is because of PPRM, that is preterm premature rupture of membrane. Features will be distal digit amputation and craniofacial anomalies. Okay, here is a picture of amniotic band syndrome. You can see that the band-like structure is formed in the distal digits, and ultimately the distal digit will get amputated. As you can see here, the distal digit is amputated. So it is the amniotic band syndrome. Here is another image of amniotic band syndrome. You can see the constriction band seen in the fingers all over here. And here these are the distal limbs are amputated, distal fingers are amputated. Amniotic band syndrome, it is due to the preterm premature rupture of membrane, distal digit amputation, craniofacial abnormality we already seen. Now phocomelia. Phocomelia is limb defect. So proximal limb amputation due to thalidomide exposure. Okay, so it is called as a phocomelia. Now presentation of oligohydroamnios. In the late pregnancy, it will be as a cord compression or fetal distress, meconium aspirated syndrome or clubfoot or CTV. In the early pregnancy, it will be as a lung hypoplasia and limb amputation. The thing you need to know about Porter syndrome is Porter syndrome. Porter syndrome can be because of oligohydroamnios. We will remember is that is a POTTER. P for pulmonary hypoplasia, that is lung hypoplasia. O for oligohydroamnios. T for twisted skin and wrinkly skin. Twisted face, that is also known as a Porter facies. Extremities deficit and renal agenesis, that is bilateral renal agenesis. This is the baby having Porter syndrome. We can easily see that the skin is a wrinkle skin, face is having a wrinkle face, face is turned to the one side. You can see the wrinkle skin over the hands.